You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. I recently sat down with Spencer Dorn, Vice Chair and Professor of Medicine at UNC. We discussed Spencer's career path, changes in medical note writing, and the value of slowing down to create better decision-making and deeper patient connections. We also talked about AI and its growing involvement in medicine, and how AI could present opportunities to rethink and innovate in clinical documentation and workflow. Let's plug in. Dr. Dorn, welcome to the podcast. Where do we find you today?
I'm in my office in Chapel Hill, North Carolina.
Awesome. Well, that's a good place to be. How's the weather?
Surprisingly cold. Yeah, it snows. It snows here about once every couple of years. It happened to snow this weekend. So exciting for kids, a little cold for their parents. But yeah, beautiful sunny day otherwise.
And how long will the snow stick around for?
Oh, usually just a day or two before it warms. In fact, most of it's gone already.
Yeah, that's the best kind of snow, in my opinion. Snow that comes down and then 2 days later is no longer there. All right. Well, I've gone through a list of the things that you do. You're a gastroenterologist, practicing gastroenterologist. You're a vice chair and a professor of medicine at UNC. And so my first question to you is, what have you done wrong? Why have you been punished so with all those jobs? And how can you fix some of the mistakes that you've made so that you can get rid of some of those jobs? Or do you like those jobs?
Yeah, actually, I consider myself quite lucky to have a bunch of different jobs. It's a privilege to be able to do different things. And while I love clinical medicine, I also like working with other people outside of clinical encounters. I like writing. I like learning. I like building new products. And for me, it's not a punishment. It's actually a privilege to be able to practice gastroenterology, which I'm biased, but I think it's a specialty that really gives a broad view of healthcare because we do so many different things. We take care of people in the hospital and the emergency department, outside of the hospital and clinic. We do procedures and a lot of cognitive work, acute and chronic care. So gastroenterology for me has always been a great vantage point for considering what American healthcare looks like. And the academic work is great as well. Working as a vice chair of a large department helps you realize that regardless of the specialty or the discipline, there are actually very common challenges and opportunities in medicine. So that's been wonderful. Being a professor is fun, get to write and present and work with a lot of young people who are in training. And then I do some informatics work as well. So I'm privileged to have a few different responsibilities for sure.
Well, that's great. And I'm assuming they all kind of overlap and help you, especially kind of your operations and technology backgrounds.
Yeah, definitely. I mean, I always say I'm not a technophile per se. I don't wear an Apple Watch. I'm never waiting online at midnight to get a new release of some product. It was really through clinical operations that I got interested in technology, healthcare technology. And it was really through clinical practice that I got interested in healthcare operations. So through practicing medicine, I started wondering, why do we do things the way we do? And how can we do them better? And then through getting involved in trying to make things better, start to recognize the central role that technology, most notably the EHR, but various other types of software influence how we organize ourselves, how we practice care. So coming from that perspective, just, technology, it's not that it's something magical. It's just something I see as quite interesting, but as an enabler to hopefully do things better.
I feel, though, at the beginning, you were talking about not wearing an Apple Watch or staying up late. I feel like you were looking directly into my soul and I feel seen and also disrespected. Although I'm an Apple fanboy, but I do not stay up late for new releases. But I do have an Apple Watch, so that's interesting. You kind of varied from where I think most physicians just say, "Why are we doing it this way?" and then they're done. They ask the question, but they don't start pursuing it. They don't see that. They don't feel like they have an ability to change the system. You've kind of adopted a different attitude. So did you have an intention to do that when you were kind of in training, that you were going to do this, or did it just kind of, you stumbled into from one thing to another, ask questions? People are like, well, that's a great question. Why don't you help us answer that question?
I think a combination. I think I'm wired. I'm innately curious. And although I'm actually an introvert, I really love working with people and speaking to people and understanding their perspective. So I think I'm somewhat inclined towards it, but no, I did not go through medical school and residency and fellowship saying, oh, I'm really interested in operations. And as you know, you get relatively little exposure when you're going through training. It was more after I completed training. I became a health services researcher, doing kind of health services research, and I really liked doing it. I wondered a lot: is anyone reading my stuff? Am I making a difference? So I said, let me at least hedge my bets and do something a little more practical that I can see a little more closely the impact I'm having. I saw some challenges with how we were doing things in our clinic, so I kind of volunteered to help change things a little bit. And as you know, usually the reward for work is more work if you do it well. So yeah, for about a decade, I helped run our clinical GI program, which I'm incredibly proud of. Amazing people working here. And yeah, just one thing led to another. So I can't say it was necessarily intentional. It was just kind of happened organically. But I do think I'm the type of person who likes to kind of get nerdy about some of these operation things. And I do like to work with people and hear about their ideas and how we can make things better. So combination, nature and nurture, like most things.
That's great. All right. We've come to the questioning part. You're good at test taking. I'm assuming you've been taking tests for a long time. This is a true or false question. True or false? Electronic health records are the root of all evil. True or false?
Yeah, I'd say a hard false there.
Hard false. Okay.
False.
All right.
Yeah, everyone wants a boogeyman, right? We all want to have a simple answer for why things aren't going so well. And as you know from some of the writing I've done in our prior discussions, the EHR has emerged as this convenient scapegoat for all the problems in medicine. EHRs certainly are not perfect, and we certainly can use them much, much better than we do. But it's a bit foolish and silly, I think, to suggest that EHRs are the reason why we're all burned out or unhappy with healthcare. It's just too overly simplistic. I practiced before I was in medical school and residency and training before EHR, so I saw the analog world, and it's clear to anyone who's practiced on both sides of the kind of digital implementation that there's been some things are much better today than they used to be, right? EHRs actually have brought us a lot of benefits, and then some things are worse. And it's just we have challenged, I think, as human beings to take this kind of broader view and not try and zero in on a really simple explanation for our problems. So no, EHRs are not the root of all evil. We could talk about why some things are much better with EHRs. Some things are likely worse with EHRs. Let's avoid those simple binary distinctions.
Well, so let's talk about some of the things that are good. I think data sharing is, well, even that we can argue about, but information is no longer tied to a piece of paper in the medical records department that you'd have to go down. I remember as a resident literally going through vaults looking for an old record. All of that information is widely available. Everything's available, which is the good news. And the bad news is everything's available.
Yeah, totally. I mean, and also I have terrible penmanship. I don't know if I had to become a doctor to justify it, but right, notes were hard to access, and they were often illegible, right? So it was you'd have to trudge down to your medical records department, or you'd have to wait for a fax from another hospital to send something over. And then even once you got it, it was often hard to make sense of. So now, as you mentioned, Craig, it's easy to get information, certainly within your own practice or health system, and often in adjacent systems as well. It's quite easy to get medical records of notes, labs, test results, etc. The challenge, as you mentioned, is that it's so easy to get information, and it's also so easy to collect information, right? So the old days, again, I'm not one of these old days were so much better, but it took a little more effort to record information. So we were a bit more parsimonious with what we recorded. And now it's just so easy to grab a whole bunch of information and throw it in your note automatically. So we have these loaded notes that we can read, but often can't make sense of. They're unintelligible. So yeah, I think the most obvious benefit of EHRs is information is widely available and easily accessible. But as you mentioned, the downside is it's so easy to grab information and to document things that sometimes that information is really low quality.
Yeah, I recall being a fourth year medical student, and I was rotating in the ICU. And my note was awesome, I thought, and it was a page and a half. The attending's note was maybe 4 or 5 lines. What felt bad for me was that the attending's note with 4 lines said so much more than my 1.5 pages of medical school.
Totally.
Like, here's a list of the meds the patient's taking, and here's a list of the labs. I don't know what's important, so I'll put it all in here. And you could see as the training went on, people became much more sophisticated about what they wrote down, and they only wrote the things that were important. And we've lost a lot of those skills with the electronic health record, with the advent of the EHR. There's really nothing you can do about that, I don't think. How do you teach residents and medical students how to write a note? Or is that a part of academic training at UNC? I'm putting you on the spot as if you know about all training for all.
Yeah, I can't speak to all training. I think, well, to go back to your point, it's like the Pascal quote, right? I would have written a shorter letter if only I had the time. It takes more energy and discipline to write a shorter note. Your ICU attending was able, well, he or she was far more experienced than you were. So they were able to sift signal from noise, and they had a little more discipline to only put on paper what was necessary as compared to as an eager medical student, right? You think everything's important and you want to make everyone happy. So you think more is better. So I think a lot of the challenge of digitizing notes is that it's so easy to create them that why put any discipline into what actually is going in there? I think there's a value to writing notes. It's not just a useless exercise that many of us have come to see it as, but it's actually an exercise in reasoning and information synthesis and the like. I can't say what happens for all of UNC medical training. I can tell you what happens when I attend on service with fellows is I always implore them to write shorter notes and not to load up their assessment and with, mix. There's a lot of mixing, right? You write an assessment of this is a very sweet 82-year-old woman who has a history of X, Y, and Z who, ate a, pumpkin pie last week. And this week she's coming in with GI. Like, how do we shrink the amount of it? Like, how do you critically synthesize and pick out what's important for your assessment and keep it really short and brief, and your plan as well? So that's what I encourage some of the trainees I work with. I am also a bit of I probably annoy them that I tell them their sign out notes, the column in Epic, if you use Epic or other medical records, that like for inpatients, that is a brief capsule of who the patient is in case someone else has to quickly learn who they are if they get called to the bedside. I'm a big stickler for, at the end of each day, go over that and condense it to 1 or 2 sentences. One, it will help your colleagues out, but more importantly, it will help you make sense of who the patient is and what's going on. If you have a busy team, it's sometimes hard to remember who everyone is. So a lot of it is like we need to avoid some of these shortcuts that the EHRs give us and think a bit harder about what we're doing and put a little more effort into some of these activities.
There are not a lot of voices in medicine that are kind of proposing, or at least emphasizing, the importance of note writing as part of patient care. But you've been writing about it. C.T. Lin from University of Colorado has been very loudly stating that he's concerned that that automating that process, just having some AI write the note, well, it might accurately reflect what's happened. It doesn't give the clinician the opportunity to kind of think back, think through. When I was writing a note, I'd always think about, what do I need to know 6 months from now when I've totally forgotten this encounter?
Totally.
That helped me figure out what was most important.
Yeah, no, I think note writing, and I like CT. I completely align with his views on this, and I've spoken to him about this and read some of his thoughts on this. We too easily think it's just busy work, right? It's just like, right, like all this pointing and clicking and typing, as if we're doing it just to satisfy some administrator or payer somewhere. But that's actually not. Yes, there is an element of that. And I understand why physicians recoil at feeling like they must do some of these activities. But there's a lot more value to writing notes and a lot of the other activities we do. And I believe a lot of this is intrinsic to clinical medicine, right? Forget about the billing requirements and the coding and all the other things. A lot of clinical medicine involves writing. Why? Because writing is part of how we think. There's this great quote that I stumbled on that is along the lines of, if you think you're thinking without writing, you just think you're thinking, right? Like writing is so intrinsic to just how we frame things and how we make sense of information and how we form our thoughts. And we shouldn't just look to get rid of that. Some of it, yes. Some of it's annoying. Some of the things we write, maybe, but at least in my mind, the assessment and plan portion of the note is just so critically important, I believe, to clinical reasoning that we have to be careful not to give it up.
Are you a soap note kind of guy or an APSO note kind of
I'm an
guy?
APSO kind of guy.
Okay.
But yeah, I mean, yes, I'm probably, and I don't want to pretend like my way is the best way. I actually type my notes with patients sitting in front of me. I type quickly and I can look at them in the eye, and typing is probably the most, the best class I took in middle school or high school. I don't remember when I took it, but probably the most valuable one. So a lot of my note I write before I see a patient as a specialist. Another thing we don't talk about enough is a lot of the note we, especially for specialists, but also for hospitalists and sometimes primary care physicians, is created before we see the patient, because who is this person I'm seeing for the first time, and what relevant tests have they had? What relevant treatments have they had? What was their weight? They have gastroparesis and they have difficulty eating. What was their weight when they were seen in clinic a year ago, et cetera? So a lot of my note I actually write before I see patients. I kind of like doing my homework in advance. And then I write a lot of the note I write during the encounter. And then afterwards, either in between patients or at the end of the day or at lunch, working through lunch, I kind of polish them off. And arguably, I spend maybe too much time on notes, but for me, it's just part of how I practice.
Well, this would be a good time to talk about a post I saw that you wrote where you were interrupted in terms of seeing a patient, and you had to say, "Oh, I gotta get out of here right now." Left the room and said, "I'll get back to you later to finish this encounter and to tell you my thoughts." And you wrote a piece quoting Daniel Kahneman's book, "Thinking Fast and Slow." Can you tell us a little bit about this? What did you learn, and how can we all leverage that kind of information?
I'm a big Daniel Kahneman. Full disclosure, I'm a big Daniel Kahneman fan. Just passed recently, actually. I think his work, I think, was just. You don't need me to judge it, right? He won a Nobel Prize. He's world famous for a reason. But I was in clinic with a really sweet older woman and her husband. They had waited several months to see me, and they drove several hours to see me. We were hitting it off. They're just some people that you just have really good chemistry naturally with. And things were flowing really smoothly, and felt like, we were starting to uncover some things that were important. And I think I had just examined her and was coming back into the room to discuss with her and her husband what I thought was going on and some options for moving forward. And I got interrupted with a personal emergency, and I had to stop the visit like on the spot. And I was terribly embarrassed. So yeah, I explained, they were really nice, and they were apologizing to me. Sorry, you have to deal with this. But I said, I'm gonna call you tomorrow. We'll do a video visit to wrap up. And I dealt with the emergency. And that night I was thinking about her, because I was like, this was the first time in my career this had happened. I had a really good idea for what I thought she needed in terms of therapy. And it wasn't an obvious idea. And the next day we did this video visit to kind of wrap up what we had started the day before. I proposed this to her, and I just felt like I understood her problem so much better than I would have if the day before. And I think it was just time and space. And it was almost like subconscious. I was subconsciously thinking about her and reasoning. And it was just really made a deep impression on me that so much of what we do in medicine, right, we're time pressured. And I get a lot of time to see, especially compared to most physicians. I spend an hour with new patients. I'm very lucky to have that privilege because I work in an academic system and I see people who have really generally complicated problems. But even that's not enough time sometimes to really consider what's going on. And it just reminded me of Daniel Kahneman, how, the whole thinking fast, thinking slow. So much of what we do in medicine is thinking fast by necessity. Because, right, if we slow down, we're going to keep someone waiting. Someone's going to be angry with us. And, we've got to get through our day. We want to get home to our families for dinner on time. All those types of things. It just made a big impression on me that, like slowing down and not feeling pressure to have the answer on the spot, sometimes it's really valuable. And, we have to remind ourselves that we don't need to know this answer today. We can get back to people. That was a really nice teaching moment for me.
Even with your informatics and your operational and clinical leadership responsibilities, knowing that efficiency is not always the goal for physicians to be ultimately efficient. You're reminding me of Brian Vardabedian, who I think you know. He was on the pod last year, and he talked about sub-optimized workflows, where basically adding friction to workflows to slow people down, because efficiency is not always good. And I think we don't want you to stop your clinic in the middle of the day routinely for personal or clinical emergencies. That's not the goal. But how do we kind of, I don't know if you have any thoughts about how do we kind of build in some of these some friction or some trip points where it's just like, yeah, you're going to have to sit and think about this because the dictation is not available for 30 minutes, or that's not a real answer, but there's something in there. Is there some way of kind of leveraging forcing us to do that slow thinking? I don't know if it's possible.
There probably are ways to engineer it. I don't know if we need to engineer so much as we need a little more space, and we need a little more compassion towards ourselves, humility. We need to ease up on ourselves, I think, a little bit and create a little more space to slow down in our thinking, or to take more time to chat with our patients about things that are completely unrelated to their clinical condition, right? To hear about their pets or their grandkids, or right, the things that most of us go into medicine for. We can't over engineer our interactions into these like really discrete, predictable, time pressed encounters. I think we need to create a little more space to have more flexibility, to think more slowly, or to connect interpersonally more deeply, or just to have more time to catch up on things. Because if you know from operations, like healthcare it's not like trains running on time. All the little delays throughout the day build up, and then, you're apologizing to a 3:00 patient. You're starting their procedure at 4:00 because you had a really difficult polyp to remove 2 hours earlier. I think it's engineering is important in healthcare, and we need to be efficient because we're limited resources, and there are a lot of people who need us, and there are lights to keep on and bills to pay and all those types of things that are very real. At the same time, I think we can't over-engineer, both because, right, things don't always run as planned, and we need time, we need space to connect.
Yeah, I love the concept of friction in designing in friction into workflows and procedures and people's days to slow them down, even subconsciously. Some things should be difficult. We're specifically not going to put defaults here in this technology or in this part of the EHR, because we want you to think about it. If that slows you down, or if you sometimes pick the wrong answer, that's okay. Well, let me pivot to one of the required topics on a podcast, which is artificial intelligence, AI. We're required by state and federal law to talk about that. There was a recent article in JAMA that showed that physicians who had access to ChatGPT actually did not enhance their diagnostic reasoning, accuracy, or speed. And then there was another study that showed that LLMs outperformed doctors in diagnostic reasoning and accuracy. So my question to you, Dr. Dorn, is what are you and your physician colleagues planning to do when you're out of a job, probably next year, and AIs take over? Like, what are your other plans? Do you have artwork? Are you a woodworker? Like, what are you going to do?
I was hoping to become a podcast host, but there's stiff competition.
I feel like that's also going to be taken over.
The first thing I'll say is there's a great quote by a pioneering informaticist named Warren Slack, who was an internist at Harvard. And I think he said this in either the 80s or maybe the early 90s. And he said, if a physician can be replaced by a computer, then he or she deserves to be replaced by a computer. So if the computers can do things better than we can, fine, right? Fine. Let's let the computers do it. I think the computers certainly can do many things better than we can. And I think it's fine for us to acknowledge that. But I think there's a gross oversimplification of what physicians do. And there's this public perception of physicians as, what do? We intake data, we output diagnoses, and we prescribe things. Like that's, like we're these little automatons that walk around, input, output, output. And as you know, as a physician, and I think as many non-physicians realize, that's a relatively small part of our jobs. We do so much more than, input, output than is appreciated. There are thousands of things we do, and the very basic, simple, everyone has this view of just input, output, or they either think that's all we're doing or all we're doing is writing notes, right? So let's just automate all this. And I think it's just an overly simplistic view of physicians. In terms of the JAMA paper that you cited, one thing I've been thinking about a lot about recently, I've thought a lot about that JAMA paper, really brilliant study. And as you mentioned, what it showed is that large language models can outperform physicians on these, diagnostic and clinical reasoning on these vignettes. And what's really interesting also is that when physicians were given these language models, they didn't perform any better than they did without them. And speaking to the author, one of the lead authors of the study, what's really interesting is that physicians use these tools like a traditional, like Google or search engine, right? So they actually didn't really know how to use they didn't know how to use the AI. So I think one thing that to me that's really interesting about that study is, as physicians, we probably need to avoid these fears like AI is going to take over our jobs, because that's just silly. And instead recognize that AI it's a class, right? It's not one thing. It's a class of powerful tools. And we should spend a little bit of time and effort learning about these tools, not necessarily learning about, foundation models and, the deep science behind it, but what are these tools? How do they generally work? And how am I supposed to use them? So those are just a few thoughts. I probably rambled a bit. So bring me back to your line of questioning, but
Well, I think that was really the main gist, is that, hey, just giving these doctors this tool and saying, it's almost as if you gave me an endoscope and say, well, you're a physician, go, put this thing somewhere. It would have a bad outcome because I'm not trained on that tool. And I think what we're seeing is a lot of research where, we didn't train anyone on these tools. And then we are shockingly finding that they don't know how to use them.
Yeah. And the good news is it's not super hard to learn so they say in training, you probably need to do at least 150 colonoscopies before you're feel like you even know what you're doing. And in truth, you probably need to do 1,000 before you're relatively competent. You don't need to spend a year playing with ChatGPT to understand these tools. I think some basic education of understanding these are probabilistic models and just the basics of how they work, or if it's a predictive algorithm. Right, language models are not all there is in AI, of course. But then, right, I don't know. A lot of people are like 10 hours is probably enough. 10 hours of playing with these things is probably enough to develop enough understanding of these tools. So it's not this, like you have to learn how to do cardiac catheterization or how to, ablate atrial fibrillation. Orienting ourselves with the basics of these tools, not being afraid, not fearing we'll be replaced, because, maybe one day, but as, Keynes said, in the long run, we're all dead anyway. So in the short term, we're not being replaced. These are tools that can do some things really well. Let's just learn how to use them. And that doesn't mean going off and getting a master's degree in computer science.
One thing I saw that you wrote, I think you wrote about Henry Ford's quote that if he had asked people what they wanted, again, when he was developing a car, they would have said faster horses. And oftentimes we use technology as we are now to automate what we already do now, the way we understand it and now. And so we're using an AI to write a note, maybe not be the best note, but it's faster, it's more efficient. I think you've been talking about, hey, maybe it's time to rethink clinical documentation. Why are we using this very advanced and expensive technology to write old-fashioned notes? Maybe we need something new that's not even a note at all. So what is 5-10 years from now? What are we doing? How are we communicating what happens in medicine?
I think we're likely doing the same thing we are now. Doesn't mean we should be, right? Change is very hard in medicine. There are a lot of regulatory requirements that many blame for the length of our notes. If you compare American physician notes to notes from doctors in Europe. Our notes are much, much larger, or I should say longer. What's interesting is a lot of the requirements, the documentation requirements changed a couple of years ago, as you know, but our notes length didn't change. So a lot of us are writing much longer notes than we must, than what payers require, but it's just this hard to change behavior. No one likes to change. My point with the Henry Ford quote that gets used a lot because it's such a good quote, but probably overused, is that maybe AI creates a new window, a new opportunity that instead of writing our long, bloated, mostly crappy notes faster, maybe we could rethink clinical documentation altogether. Now, maybe it sounds like I'm talking out of both sides of my mouth because earlier I said note writing is really important. But what I dream of sometimes is maybe we could just write our impression and really high level what we're thinking and passively collect all the other data. And then when Dr. Joseph needs to see the patient I saw a week from now, the AI can instantly synthesize and assemble and pull together the right piece of information that he needs at that point in time. So instead of writing these long static documents, maybe we can just create little packets of information that we think are important for someone else to know and file that away. And then later on, allow more dynamic recreation of the information necessary at that point in time.
What about bringing in patients into the note writing process? Where do my thoughts go as the patient?
I think that's important. I think the patients can and should and certainly do have a say. And now that we're increasingly using ambient to record conversations, that's being passively collected as well. I think we'd have to be careful not to create even more burden, right? More effort towards doing this. But I would love a world where we use passive data collection and blend it with some active, thoughtful information capture. And then later, depending on the need at a given point in time and what, who's seeing the patient, what their need is, reassemble dynamically the right information rather than having to look back at notes. As you know, notes are just part of this old paradigm. In fact, we have tabs in our EHRs because it recreates the old tabs in a filing cabinet, right? EHRs are largely filing cabinets. I don't need to tell you this as someone who's a design thinker. That's the faster horse, right? And now we're speeding the horse up. We're giving the horse steroids by not only having us digitize these notes into these, hypothetical filing cabinets, but now we're just automating a lot of that note writing process. And I think we could do better, but I'm also realistic. And I think change will take a long time.
We're getting to the point where the regulations and laws are kind of catching up, maybe, or at least contemplating catching up. And so it used to be the physician note was the end all be all of what happened at that office visit or that progress note on that hospital day or the procedure note. That was it. There was no other information that could be leveraged to understand what happened. And now we, as you so eloquently point out, there's so much other information out there. If we can just pull it in at the right time for the right audience, dynamically and say like, hey, here it is. As long as we're allowed to do that and people understand the downsides and the benefits of doing that, then we're in a good place.
Completely agree.
Awesome. Well, this has been a great conversation. As with all of our conversations, great or not, we always end with the same question. If there's a product or a tool or a process in your life that is so well designed it brings you joy, what are there one or two things like that are just epitomes of design for you?
One that came to mind, which maybe someone's shared on your podcast before, probably not, is I use this great little meditation timer. It's a digital timer with almost no features. It's called the Enso, ENSO, which is a Japanese word that relates to Zen. It's essentially a circle without a beginning or an end. And this timer is designed in the spirit of that. And it has, you could set the time and you could set the sound of the chime and the volume, and that's pretty much it. And what I love about it is its simplicity. It's not like you're meditating with your phone next to you, because the last thing you want to do after you meditate is, get on Twitter or the Wall Street Journal, whatever you read. So it's just like highly functional, does exactly what you need, but it's super simple and does not draw you into things you don't need to be doing. So
no, that's a new one. That's great. That's great. It's a specific tool, and it does what it does well, and it doesn't do anything else. I love it. It kind of reminds me, I've seen these, what we used to call word processing. I think we call it typing or writing now. But these tools that are essentially just typewriters. They're like a computer, but they don't connect to the internet, or they do, but they only for storage and to try to get rid of all the distractions so that you just focus on what you're supposed to be doing. This was great. I really appreciated the conversation. Thank you so much. You're forward thinking, and I would encourage everyone to listen to you to read your writing, which is, I think, mostly on LinkedIn. Is it anywhere else?
Yeah, I've been writing for Forbes recently as well. So something a little bit longer form, still relatively short, but a little more than a LinkedIn post. Yeah, and people could check out the work we're doing at UNC. Very proud of our department and our health system here. But yeah, it was great speaking to you, Craig. I really enjoyed this conversation.
Thank you so much, Dr. Spencer Dorn. Thanks for tuning in. We hope you enjoyed today's episode. For more on Spencer, follow him on LinkedIn at linkedin.com/Spencer-Dorn. Check back for more episodes of Designing for Health wherever you listen to podcasts, or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.